going to do the fourth case of today. He is a male patient, Jidya, 1 year, 10-month-old, weighing 11 kg. He was diagnosed as a case of 8 mm ASD secundum due to frequent respiratory tract infections and recurrent fever. And while examining the patient, after having systolic murmur, ASD was primitively diagnosed, and after doing investigations like chest X-ray, which revealed cardiomegaly and plethoric lung field, and ECG showed RVH, right ventricular hypertrophy, and right bundle branch block, RBBB. And after that, it was confirmed by echocardiography, and it was revealed that there was a large ASD secundum, 8 mm, mild PS as well, and also mild tear, dilated RA and RV, and the ventricular functions are very good. And today he is going to be operated for ASD device closure by Brigd Nurunnahar Fatema. You know, the live workshop is going on minimalistic approach of transcatheter interventions in congenital and structural heart disease. Brigadier General Professor Nurunnahar Fatema, she is doing all the procedures and supervising everything.
Have crossed, and just to mention in our you have seen I already crossed, and as I have mentioned, we planned everything from beforehand. So this is a 10 mm ASD which is gradually increasing in size. You have seen the age. Age is 17 months, I think, and in his subsequent echo, ASD is getting larger. So to close it, to take the chance of closing it with the device. So you have seen I have applied some tricks here because we are almost closing the wire, and wire was in the left atrial appendage. So if you enter into the left atrial appendage with the delivery system, there is chance of complication, and this left atrial appendage is the commonest site for rupture and then complication. So you have to be careful from beforehand and to take appropriate measures to avoid complication. So we have applied some tricks, and we are now inside the left atrium with the delivery system, and now we have selected in the minimalistic approach. I have mentioned that we select and we plan our procedure from beforehand. So we have already selected a 12 mm size ASD device for this child, and again I am saying that minimum in the size, better is for the patient. So we can give, as his interatrial septum total IS is 32. So in this child, as interatrial septum is 32, we can go up to 16. But we will not give him a 16 size. It is better to give as less as possible, because you know there are conduction system, and there is chance of pressure effect on the conduction system, and there is chance of complete heart block. So we always avoid that, giving pressure effect on the conduction system. So now we are checking whether the delivery system is in proper position with good flow, good free flow of blood. We are not getting free flow, so we will try to adjust the position. So this is now out. So see, this is now out of the left atrium. I will not take any chance of any air embolism, so I have taken it out as there is no free flow. And now I will go again. So it is better to do from the beginning rather than to do any complication. So I will take some time again to go to the left atrium with the help of, again from the beginning. Air embolism is the most hazardous part of the ASD device closure procedure. So you must be careful, and you must avoid air embolism at any cost. So this is again inside the pulmonary vein. I will try if I can cross. So you have crossed already. And now we will check whether there is free flow. Again we will check whether there is free flow of blood. inside the delivery system. This time there is very beautiful free flow. Can you concentrate on this? So you are seeing here that there is free flow of blood coming out through this side port, and we are happy that there is no air inside. So we are connecting the device with the delivery system now. This is a 12 size which was pre-planned. So we have planned the smallest size as smallest as possible. It is better if it slip out. We can again change it to a larger size, but try to give a smaller size as small as possible, because this is the atrial septum through which sinoatrial node is communicating with the atrioventricular node, and we must be careful about the conduction system. So the maneuver you have seen just before was that I was using a GI catheter and the pterygium wire, and through that I was able to cross the delivery system. But this is little bit of the difficult tricks, and once you are experienced, you will be able to do that. But this is not for the beginner or not for the one who are doing this procedure very infrequently. Now I have immersed the delivery system under the water, and I will do everything underwater. So now I am trying to de-air the delivery system and its side port. We are flushing now, and then now we will pull back. So you will see now that we are pulling back, and look at the syringe. Look at the syringe, you will see now that blood is coming. So this is the thing which we love to see, and there is no air. At the same time, we have to keep our eye on the monitor to see whether there is any air embolism. If there is any air embolism, in that case, you will see change in the ST segment, and then there will be Brigd. If you do not take measures, there will be Brigd. Now the device is fixed against the atrial septum. So now I will uncover the right atrial disc. You are seeing I am uncovering it, and it is going up. And now I am taking the things out of the water, and we will do the Minnesota maneuver. You are seeing now we are doing the Minnesota maneuver, and this device is tightly fixed. So now we have some other tests to see whether it is okay or not. So we will check in the angiographic long axis view. So this is a profile view, and you can see here also that this is very nice. And now we are going to the echo. Everything is fine here. Transparency window is very good. We are seeing everything properly. Our ECG is good. Patient saturation is 100% at the moment. Heart rate is 115 per minute. All vital parameters are normal. ECG normal. And we are happy with the TARC test. And we are happy with the echo also. So finally, I will do the echo by myself. And Alhamdulillah, position is good. So you are seeing now the device is in position. So this is the final echo view. You are seeing very nice alignment of the device. And we are done with this case.
Echo showed inferior rim was 12 millimeter. I think
Yeah.
it's good enough.
Yes.
And superior rim was 7.5. So though
This is a small child. Echo
Yeah.
showed increment of size in every follow-up.
yes, madam.
So we are trying to close it. Otherwise, in next follow-up, it will be 2 millimeter more, and then in next 2 more, like this. So this is the way, is the natural history of the ASD. And in adult, if this child become adult,
Yes,
the ASD will be like 25, 30, 35.
Exactly.
So why should we allow the ASD to increase? That is our logic.
yes, madam.
Thank you.
Yeah, well done, madam.
I want to introduce you with my team member who are working here. So first of all is Shah Alam, Jami Alam. He is the radiographer, and he is very wise person who helped us in our decision making. Sometimes we are in dilemma. We don't know what decision will be good for the patient. In that case, I have a voting system. So first of all, I ask Jami Alam. So he always helps us with good decision. And now is Anwar. He is the most important team member because he knows how to organize a case, and then to help us with all the support like hardwares and everything. Because if you don't have all the accessories with you, you will not be able to complete a case. And now is Lieutenant Colonel Nazmul is my student, and they are very dedicated. Whatever I ask them to do, they never ask me any question. They just go and do that. So they are very obedient student, and they are very actually, I think they were a good student in their academic career, and they are becoming a very good pediatric cardiologist for the future. Ashwin. And now is Lieutenant Colonel Ashfaq. He is another student, and he is also very sincere, dedicated, and they always work with me. And whenever I ask them to do anything, he is also like Nazmul, and both of them are very hardworking, dedicated, and they will be very good specialists in pediatric cardiology in future. Currently, they are already their pediatric cardiology, but still they are learning, because learning has no end. So they are now doing also the course in pediatric cardiology FCPS. But long time ago they were trained from India for long 1 year in pediatric cardiology. It was in 2010. It was in 2011. So 10 years ago they were trained. And now is the Shah Alam. Shah Alam is one of the another important member. He knows how to take care of vital signs, how to maintain the vitals of the patient, and he is a very important member, because if your patient is not stable during the procedure, after the procedure, then you will have no outcome. So he is the one who takes care of this thing with us, and these are the core members, but there are many other members. Today we have our sister here. Joy is here with us. He is assisting us in our cases. She is assisting, and there are other nurses also. Gradually, I will introduce them with you in our next cases.
So we have ended up with our fourth case, and the first case of ASD device closure. You have seen that how critical it was. Every second is so precious, and every team member were so keen and so attentive to all the procedures, all the part of the procedures. And if you need a good success, a great success, you need to have a good collaboration as well. The second case is going on. She is Fatema, and she is only 1.3 years old, 11 kg, and she was diagnosed as a case of PDA, having complaints of recurrent respiratory infections.
You are seeing that there is total occlusion of flow, which is known as stop flow. So there is stop flow now, and in the fluoroscopy we are seeing that there is waste formation. So this is the size which we want, and then outside the body we will measure the balloon size and we will select the device. This was the balloon inside the ASD. Now we have filled the balloon again with the plant, with the dye, and which was 1:8 dilution. And now we are measuring this balloon, matching it with the sizing plate. So this is the 14, which seems to be similar to that of the appearance in the screen. And according to the echo, there was stop flow, so this is just the stop flow. So this is 14 size. This patient's IS is 42, interatrial septum, and as the rims are little bit floppy, we are going to give a 16 millimeter here. This is the size of the delivery system. So we were actually waiting for some time to see. I was saying that there was too much depth on the contact side. So I just checked whether it is any arterial puncture or not. So in every place you have to be careful. If you have anything in mind, you have to check that and then you proceed. So we did the analysis, blood gas analysis. Saturation is 70%. So it is done. So we are in the LA rim open. LA disc is now in position, and now we are against the atrial septum. You are seeing that atrial septum is pulled down with the device. Now I am releasing the right atrial part. So this is the right atrial part, and now we have finished with the walkward. As this was a plus minus case, large ASD in a small child, which we will check several times before releasing the device. So we see the Minnesota. This is fine. You can see in the echo screen that the lower end of the device is in nice position, and the inferior ring and aortic ring is inside the device. This child's ASD is getting larger every day in subsequent echoes, so we have decided to close. And as this is a very large ASD, we said we will try if it is possible. If not possible, then we will refer to surgeon. Now so far so long we are fine with the device. We did the TAF test or Minnesota maneuver. We find that the device is properly fixed up in the position, and other things are also, though not excellent, but not bad. That's why I am.
Which size device, madam?
This is a 16 size.
16 size. I think it's, for you, I think it's the very minimum size.
Now very small, but this is too large for a small child.
Yes, madam.
This is large for a small child.
Small size, yeah.
Yeah. Okay, now, the fluoro first and then go to echo. So we are seeing in the fluoro that device is in good position. Can you come in the frontal view, please? So we are seeing fluoroscopically if it is okay. So fluoroscopically it is fine. And echocardiographically we are now seeing whether it is good or not. As I have mentioned earlier, we have used a large size device. It would be better if we could give 14, but as it is a very large ASD with small rings, we have given one size large.
So, dear viewers, we have done 8 cases till now. Some were ASD device closure and some were PDA device closure. And now we are going to observe another interesting case. The patient is Tanveer, 6 years old, weighing 16 kg. He was diagnosed as a case of small perimembranous VSD, trivial TR, good biventricular function. And he actually complained with head sweating easily, and after examining him with doing all the investigations like chest x-ray and ECG and especially the echocardiography, the small perimembranous VSD was found there. It's an interesting thing that actually there is no such complaint, much complaint other than the head sweating, and X-ray and ECG findings are absolutely normal. So in these cases, if you are not clinically sharp, if you don't think that there might be a VSD, you will not think of that. So actually, sometimes we find some cases with recurrent respiratory tract infections, and we treat them with as a case of pneumonia and now some viral respiratory tract infections. So we need to keep in our mind that it might it might be discovered as a new case of congenital heart disease. So we need to keep it in our mind. And VSD device closure is going to be done on Tanveer, 6 years old, weighing 16 kg. So dear viewers, our madam is there. She started to do the procedure, and please keep with us. Thank you.
হলো শেখার জিনিস আছে। ওয়্যার সাপোর্ট, আচ্ছা তুমি একটু চেক করো, এই ওয়্যার এইভাবে কেন, ইট উইল কাম, ইট উইল বি ডাউন এখানে। এত জোরে দিলে তো ওটা তো ছেড়ে দিলে চলে যাবে। নাও পিছনে টানো, is the device from the coil, it will be okay. So the device now it has taken its position. Before it was little bit like upward. Now this is a very nice position, and if you see the echo now, you will be very happy. Just a minute, I want to show the fluoro also. So this is the aortogram. There is no air and device is in nice position. There is no residual VSD. So we have finished the procedure. Thank you.
Thank you everyone again to participate in the live workshop on minimalistic approach of transcatheter interventions in congenital and structural heart diseases organized by Bangladesh Specialist Hospital and Congenital Heart Desk. And the procedure is going on in the cath lab of Bangladesh Specialist Hospital, and we can view directly from that cath lab all the procedures ins and outs of that. And also our Honorable Madam, Brigadier General Professor Nurunnahar Fatema is supervising and directly performing all the procedures, and also she is delivering the running commentary so that we can learn, we can know what's going on with those cases. Okay, so dear viewers, thank you again for being with us. Please keep watching what's going on next on. Thank you everyone. Thank you once again.